Hello, I welcome you all to today's session wherein I'll be taking the pathologies of uterus. So these are the contents of today's lecture. So we shall start with anatomy of the uterus. So you already know that uterus has got three parts. The part which is present above the insertion of the tubes is known as fundus, and below that is the body of uterus, and the lower part of the uterus is known as cervix. So this is the laparoscopic view where we can see this is uterus and adnexal structures on the left and right. This is left adnexa showing the left fallopian tube, and here you can see the right fallopian tube and ovary which are placed posteriorly. Here is the round ligament. Next we come to the histology of uterus. So uterus has got three layers. So the innermost layer is endometrium, the middle layer is myometrium, and the outermost layer is perimetrium. So here in this H&D stained section we can see all the three layers of uterus. The innermost layer is endometrium. So this is endometrium. Endometrium has got a lining epithelium of pseudo-stratified ciliated columnar epithelium, and below that there is the stroma. This is stroma, and stroma consists of endometrial glands. So these rounded structures, these are the endometrial glands, and this is the stroma. The next layer is the myometrium. This is myometrium. It is composed of bundles of smooth muscle cells. And the outermost layer is the perimetrium. So this is the perimetrium, and it is composed of fibrovascular connective tissue. So these are the three layers: endometrium, myometrium, perimetrium. And one more thing I would like to tell you is that endometrium has got two parts. The inner part is known as stratum functionalis, which is shed every month during menstruation, and a basal part which is known as stratum basalis, which again gives rise to the endometrium every month after menstruation. Now this is the higher power view of endometrium. This is the lining epithelium. This is pseudo-stratified columnar epithelium which is ciliated. This is the cilia on the top of these cells, and this is pseudo-stratified because it is giving a multi-layered appearance due to the presence of nuclei at different levels. So it is not multi-layered epithelium, but it is giving the appearance of multi-layering because of the different position of the nuclei. So it is called pseudo-stratified, and the cells are elongated. So this is columnar. So this is called pseudo-stratified columnar epithelium which is ciliated. So this is the lining epithelium, and below this there is the stroma. These are stroma. These are the oval shaped cells in the stroma. The stroma also shows the glands, endometrial glands. Here you can see these are the endometrial glands. In the myometrium we see smooth muscle cells which can be seen lying longitudinally, or they can be seen in the transverse section. How we see them? In the longitudinal section, the nuclei, they are elongated, oval to spindle shape, and eosinophilic cytoplasm is there. While when they are cut transversely, we can see the rounded appearance of the nucleus. So these are the smooth muscle cells of the myometrium. Next, we come to the endometrial as seen in the menstrual cycle. So you know that endometrium is hormonally responsive, and it is shed every month during the menstruation. So during menstruation, what happens during the menstrual cycle? The ovary releases certain sex steroid hormones cyclically and in a coordinated manner, and it leads to the morphological changes in the endometrium also, and these changes are also cyclical, and this constitutes the menstrual cycle. The progesterone and estrogen which is released by the ovary, it is done under the influence of FSH and LH, which is secreted by the pituitary, and this is in turn under the control of gonadotropin releasing hormone released by the hypothalamus. So in the menstrual cycle there are simultaneous changes occurring both in the ovary and in the endometrium. So during the first 14 days there is a process of formation of the oocyte, and on the 14th day there is ovulation. After release of the ovum, this Graafian follicle, it changes to corpus luteum which secretes the progesterone. So the first 14 days they are under the influence of the hormone estrogen, and while the 14 to 28 days they are under the effect of progesterone. And because of these estrogen and progesterone effects, there are changes which occur in the endometrium also. So this is the menstrual cycle. Day 1 to day 6 or 7 there is shedding of the stratum functionalis of the endometrium, and this is known as menstruation. After that comes the proliferative phase, and on the 14th day there is ovulation. There is release of the oocyte by the Graafian follicle. After that, the phase from 14 to 28 days, it is known as the secretory phase, and in the ovary the Graafian follicle changes to corpus luteum, which secretes this progesterone. Now, what is important to know is that what are the histological changes occurring in the endometrium during the menstrual cycle. So in the first image you can see that this is the proliferative phase of the endometrium, and it is marked by the growth of endometrial glands. The endometrial glands, they are proliferating, and the stromal cells are also proliferating. So there is increase in the number of endometrial glands, and here you can see on the arrowhead there are two mitotic figures. It indicates that the cells are proliferating, and the glands, they are straight, tubular, and they are lined by the pseudo stratified columnar epithelium. So this is the proliferative phase of the menstrual cycle. Occurs up to the 14th days. So on the 14th day ovulation occurs. After the ovulation there is formation of corpus luteum, which secretes the progesterone, and under the effect of progesterone the secretory phase is seen. So what happens in the secretory phase? Till the 14th day there was proliferation of the glands, and now under the effect of progesterone differentiation of the glands will occur. So glands will start to accumulate the vacuoles in their cytoplasm. So here you can see there is cytoplasmic vacuoles which is seen in the form of this clearing. These are the glands, and there are vacuoles in the subnuclear position. So these are subnuclear vacuoles, and in the late secretory phase you can see that these vacuoles come to lie in the apical side of the cells. So and after that these vacuoles, they create secretions in the lumen of the gland. So the glands, you can see that the glands, they are filled with secretions. The glands become dilated, tortuous, and there is proliferation of spiral arterioles also in the stroma. And additionally the stroma shows pre-decidual change. On this black arrowhead you can see that the cell has abundant eosinophilic cytoplasm. This is because of the accumulation of glycogen in the cells. This is pre-decidual change. So basically endometrium is preparing itself for the implantation of a fertilized ovum if it occurs. In case the fertilization occurs, then corpus luteum does not degenerate. It remains there for the rest 9 months, and it will keep on secreting progesterone to maintain the pregnancy. But if the ovum does not fertilize, no fertilization occurs, no pregnancy occurs, then what happens? Then these glands, they break down, stroma breaks down. There is stromal and glandular breakdown. There is hemorrhage in the stroma, and along with mild neutrophilic infiltration, and this is the phase of menses. So these are the histological changes that occur at different dates of the menstrual cycle. So from this there is a concept of endometrial dating or dating of the endometrium. So endometrium dating, it is needed whenever a gynecologist sees a patient with some abnormality like irregular menstrual cycle or amenorrhea or menorrhagia or some abnormal uterine bleeding. So in that case what she does, she takes the curettings from the endometrium. There is a curette and it is inserted into the uterus through the external os, and she takes the scrapings from the endometrium, which is known as endometrial curettings. So it is sent to the pathologist along with the details of her last menstrual period and other clinical details. So we know at which date of the menstrual cycle this endometrial curetting have been sent. So we will see the microscopy and match it with the microscopic features of that date. That is called dating of the endometrium. We see whether it is appropriate or not. The changes in the microscopy, are they according to the date of the menstrual cycle or not. And this dating of the endometrium will help us to assess the hormonal status of the patient, to document whether ovulation has occurred or not, and to determine the cause of endometrial bleeding, and to diagnose the cause of infertility. So it is a very important tool to assess all these things. endometrial curating and dating of the endometrium. So next we come to abnormal uterine bleeding. So abnormal uterine bleeding or AUB can occur due to a variety of causes like endometrial neoplasms, endometrial tumors, then endometrial polyps, leiomyomas also known as fibroids, chronic endometritis which is the inflammation of endometrium, or hormonal disturbances. There is another term called dysfunctional uterine bleeding. Majority of abnormal uterine bleeding, it is due to DUB or dysfunctional uterine bleeding, and it is a clinical term which is used by the clinicians for the uterine bleeding that lacks an underlying organic or structural cause. So structural cause means presence of some structural malformation in the uterus. There is structural abnormality present in the uterus, like some endometrium tumor, endometrial polyp, or like a fibroid in the uterus. So if there is no structural cause in the uterus and still there is bleeding, so it is called dysfunctional uterine bleeding. And most common cause of dysfunctional uterine bleeding is anovulation, and anovulation means failure to ovulate. It is in turn due to the many hormonal disturbances. So this is important for Viva and MCQ also, that DUB most common cause is anovulatory cycles, and which is in turn due to the hormonal disturbances. And you can also be asked like, what is DUB? Definition of DUB. So it is the clinical term for uterine bleeding which lacks a structural abnormality in the uterus. Now next, this table is from the Robbins, and this gives you the various causes of abnormal uterine bleeding by various age groups. So in pre-puberty, precocious puberty, adolescent age group, and ovulatory cycle are important cause, and in reproductive age group, complications of pregnancy, anatomic lesions like fibroids, leiomyoma, adenomyosis, these can lead to uterine bleeding, then DUB. And in the perimenopausal age group, important causes are DUB and anatomic lesions like carcinoma, hyperplasia, and polyps. And in the postmenopausal age group, endometrial atrophy and anatomic lesions like carcinoma, hyperplasia, polyps, they can lead to abnormal uterine bleeding. So this table is very important. You should learn this table. Next we come to the inflammatory disorders of endometrium. So these are less common. Inflammatory disorders, they are less common in endometrium because cervix acts as a barrier for the ascending infections. And endometritis is of two types, acute and chronic. Acute endometritis, it is caused due to various bacterial infections and following delivery or abortion. And on microscopy we will see there is mild neutrophilic infiltration in the stroma. And in chronic endometritis, it is again inflammation of endometrium due to chronic PID, chronic pelvic inflammatory disease, due to retained products of conception. After delivery or after abortion, if the products of conception they remain inside the uterus, they can lead to chronic endometritis. Use of intrauterine contraceptive devices or tuberculosis. In chronic endometritis, there is a characteristic feature then in the stroma we will see the plasma cells. Plasma cells are not normally seen in the stroma of endometrium, but in chronic endometritis. So it is an important MCQ also that that even if we see one plasma cells, we will label the disease as chronic endometritis. And now tubercular endometritis, what we will see, we will additionally see the presence of epithelioid cell granulomas in the stroma. And tubercular endometritis is an important cause of infertility in the females. Now next topic is endometriosis. It is very important topic from exam point of view also. So endometriosis is defined by the presence of ectopic endometrial tissue at a site outside the uterus, and it is associated with inflammatory reaction and fibrosis. So it is presence of ectopic. Ectopic means it is present at a site other than the endometrium. The endometrial tissue, it is present not in the endometrium in the uterus but outside the uterus. So endometrial tissue which is seen in endometriosis, it is derived from stratum functionalis. So it is important MCQ that from where the endometrial tissue in endometriosis is derived from. Now next we come to the important sites of endometriosis. So it is important to know this list where all the endometrial tissue can be seen beyond the uterus. So ovaries are the most common site, important MCQ. Ovaries, they most commonly show endometriosis, followed by uterine ligaments, then rectovaginal septum, cul-de-sac which is rectouterine pouch, then pelvic peritoneum, large and small bowel and appendix, followed by mucosa of the cervix, vagina, fallopian tubes, and lastly the laparotomy scars. So this list is important, the sites where the endometriosis occurs. This is also depicted in this picture, the different sites like small intestine and then fallopian tube, ovary. These are the sites for endometriosis. Endometriosis, these are the common sites, and rarely they can be seen in some sites like lungs, pleura, kidneys, brain, bone, lymph nodes, peripheral nerves, and even in the nasal cavity. These cases have been reported in the history. In the literature, we can see that even in these sites, endometriosis have been seen, although they are rare. So how does endometriosis occur? What is the pathogenesis of endometriosis? So there are some proposed theories for endometriosis. So first theory is the regurgitation theory. This theory proposes that the endometrial tissue, it goes to the ectopic sites by way of retrograde flow during the menses. The retrograde flow occurs from the, it flows upwards from the cervix up into the fallopian tubes and later on into the peritoneal cavity. So this is regurgitation theory, that the endometrial tissue will reach the ectopic sites by the retrograde flow of menstrual endometrium. So retrograde menstruation is the first proposed theory. Second is benign metastasis theory. So this theory, first theory, explains how it reaches to the in the peritoneal cavity, in the different regions of the peritoneal cavity. But if we have to explain from how does it reaches the lungs, brain, bone, so for this there is benign metastasis theory, which states that there is extra pelvic dissemination of the endometrial tissue through the pelvic veins. So this is benign metastatic theory. So by blood vessels or also by lymphatic channels, it can reach to distant sites. The third theory is metaplastic theory. It states that the endometrium, it arises by way of metaplasia from the coelomic epithelium. Now what is coelomic epithelium? It is the mesothelium of the pelvis, and from this mesothelium only, from this coelomic epithelium only, the Mullerian ducts and the endometrium also they originate in the during the embryogenesis. And the last theory is extrauterine stem cell or progenitor cell theory. So this theory suggests that these endometriotic focus, they arise from the stem cells of the bone marrow. So the stem cells, they will differentiate, they are totipotent, they can differentiate into any cell type. So they differentiate into this endometriotic cells. So this is about the pathogenesis of endometriosis. Next, clinically, the endometriosis affects females in their 3rd to 4th decade, and they present with dysmenorrhea, which is painful menstruation, then dyspareunia, which is painful intercourse, and pelvic pain, because most common site is in the pelvic peritoneum. And if there is involvement of rectum, then if there are deposits of endometriosis in the rectum, then there will be pain during defecation. Or if there is involvement of the urinary bladder, then there will be dysuria also. Then other feature can be cyclical bleeding along with menstruation. So when the hormones which are acting on the endometrium, they will also act on the ectopic endometrium. So there will be cyclical bleeding at those sites also from where the endometriosis is present. For example, if there is nasal endometriosis, the patient will present with bleeding through the nose during the time of menses. So epistaxis and menses, they will occur simultaneously. Then infertility can also occur because there is cyclical bleeding, and later on there is fibrosis and extensive fibrous adhesions they form in between the pelvic organs, because of which the fallopian tube may get blocked, and pelvic adhesion extensive, they can lead to infertility. Next few lines about the atypical endometriosis. So endometriosis, generally it has the benign endometrial glands and stroma at an ectopic site, but sometimes these endometriotic foci, they may show atypia, and in case they show atypia, it becomes a precursor to ovarian carcinoma. Why? Because the most common site is ovary. So in case of ovarian endometriosis, if the endometriotic cells, they become atypical, they can act as a precursor for ovarian carcinoma. And what are the most common histologic types of ovarian carcinoma that can occur in atypical endometriosis? These are endometrioid ovarian carcinoma and clear cell carcinoma. So if there is atypical endometriosis, it can lead to ovarian carcinoma. And in atypical endometriosis, there can be two microscopic features. First is there can be cytologic atypia of the lining epithelium in the endometriosis, and other there can be cytologic atypia along with crowding of the glands of the endometrium. So this is atypical endometriosis. You have to remember that it can be an important precursor to ovarian carcinoma, and chiefly endometrioid and clear cell type. Now gross inspection. On gross inspection, we see the endometriotic foci, they have nodules with reddish blue to brownish appearance. So these are the nodules of endometriosis. They will be seen at the site of involvement. The important point is that when these lesions, endometriotic lesions, they are extensive, it will cause repeated hemorrhage and later on fibrous adhesions. Like these are the fibrous adhesions which will be formed in the pelvis, and even fallopian tube can be blocked. So this will be seen in the gross appearance of endometriosis. Now this is the again through laparoscopic we are seeing. This is the uterus, surface of uterus, and this is the fallopian tube, and on this we can see this is the endometriotic foci. These are brownish, reddish brownish spots, rounded spots, nodular. Again in this picture you see this is uterus, and these are the spots of endometriosis. This one, these are the spots of endometriosis. Now next, since most common site of endometriosis is ovary, so we should also know the gross morphology of ovary. So ovaries, but they become markedly distorted by the large cystic masses which are filled with thick brown fluid, which is known as chocolate cyst of ovary. You see, this is the cut surface of ovary. This is ovary. This has become enlarged, and on cutting we can see inside this there is this degenerated blood which gives chocolate color appearance. So this is called chocolate cyst of ovary, also known as endometriomas. So the ovaries, they become distorted by these cystic masses, and size can range from 3 to 5 centimeters, and this brown fluid, it results from this hemorrhage in the endometriotic site. So this is a chocolate cyst of ovary. The important MCQ and Viva question. So why the chocolate cyst is seen? So it is seen in case of endometriosis, and it is because of the repeated hemorrhage in the endometriotic foci. Now again this picture again shows a chocolate cyst. This is the cut surface of ovary. This is the ovarian tissue, and this is the endometriotic foci with presence of the degenerated blood. Now next, so in the sites of endometriosis, we read that laparotomy scars can also cause endometriosis. So if a female patient with a recent history of cesarean section comes, see this is the cesarean section scar, and near to it there is this reddish brown nodule in the abdomen. So first differential diagnosis will be endometriosis, scar endometriosis, and it occurs because during the operation some endometrial tissue gets trapped inside the subcutaneous region, so it leads to the endometriosis. This is called scar endometriosis. Next we come to microscopy of endometriosis. So endometriosis is presence of endometrial tissue. So in microscopy also we will see the endometrial glands and endometrial stroma, and along with that, since there is a lot of hemorrhage occurring in the endometriotic foci, so there will be hemosiderin pigment. So thus just three features: endometrial glands, endometrial stroma, and hemosiderin pigment. So in these pictures we will see this is the colonic mucosa. We can identify this colonic mucosa by the presence of goblet cells in the mucosa. So this is the colonic epithelium, and here you can see a different epithelium. This is endometrial tissue, endometrial glands and stroma. This has a deep bluish appearance, and this is the normal colonic mucosa. So this is the endometriotic foci, endometriosis in the colon. Again in this you can see this is the bowel wall. This is the wall of the intestine. Here there is the muscle cells, there is the muscle layer, and in between there are the endometrial glands and the stroma along with hemorrhage. Again this is endometriosis of the intestine. Now in this we can see in the high power that there are in the yellow oval there are the endometrial glands and stroma, and here you can see this is a wall of the bowel and colonic mucosa is there. So this is the microscopy of endometriosis. There is presence of endometrial glands, endometrial stroma, and hemosiderin pigment along with areas of hemorrhage. In this picture we can see this is a lymph node, cut section of a lymph node, enlarged lymph node, and it shows grey white areas along with this presence of these reddish brown area spots. So these are the endometriotic spots, and on microscopy HE stained sections will show endometrial glands and stroma. Here you can see these are the glands and stroma. It is a deep blue appearance, again you see. So this was all about the microscopy of endometriosis. Now we come to the next topic, which is adenomyosis. Again, this is a very important topic from exam point of view. So adenomyosis, it is, as the name suggests, adeno means gland, meiosis means myometrium. So there is presence of endometrial tissue, endometrial glands, endometrial tissue, which is derived from the stratum basalis. Now you recall that in endometriosis, the endometrial tissue was derived from the stratum functionalis, while in adenomyosis, this endometrial tissue is derived from the stratum basalis. So endometrial tissue is present in the myometrium, within the myometrium. So it's simple to remember. And the important criteria to label it as adenomyosis is that this endometrial tissue should be present at least 2 to 3 millimeter below the junction of the endometrium and myometrium, or below the stratum basalis. So this is an important criteria to diagnose adenomyosis, that the endometrial tissue which is present in the myometrium, it should be present about 2 to 3 millimeters away from the stratum basalis. So this is adenomyosis, and endometrial glands are seen interposed between the muscle bundles of myometrium. Clinically, the patient will present with menometrorrhagia, means menorrhagia means there is heavy menses, and metrorrhagia means there is irregular periods. Then dysmenorrhea, dyspareunia, and pelvic pain. Grossly, what will we see? Because of the presence of endometrial tissue in the myometrium, there is hypertrophy of the myometrium, is increase in the size of the cells of the myometrium. So this results in an enlarged uterus with a thickened uterine wall. You see in this picture, this is the endometrial cavity. This is a longitudinal cut. It is longitudinally cut. The uterus is longitudinally cut. This is the endometrial cavity, and here you can see this is the wall of the uterus which is thickened because of adenomyosis. So there is hypertrophy of the myometrium leading to enlarged uterine size. Going to the microscopy. In microscopy, what will we see? As the definition suggests, we see irregular nest of endometrial stroma which is present with or without the glands inside the myometrium. So this is the normal histology of uterus. You see this is the endometrium, this is the myometrium, and this is the perimetrium. But in adenomyosis we will see stroma with or without glands. So here you can see that this is the stroma and these are the glands which are present in the myometrium. How do we identify the myometrium? By the presence of these longitudinal smooth muscle cells. These are the smooth muscle cells, bundles of smooth muscle cells here also. So in between the bundles of smooth muscle cells we can see the endometrial glands and endometrial stroma. If only stroma is present, then we label it as stromal adenomyosis. And here also the important criteria repeated, that this foci should be present about 2 to 3 millimeter from the stratum basalis. Without this criteria we cannot label it as adenomyosis. Now this is the last topic, endometrial polyps. Just briefly I will tell you. So these are the exophytic masses about 0.5 to 3 centimeters in size, and they are projecting into the endometrial cavity. Important point which also comes in MCQ, that it is associated with tamoxifen usage. So this drug tamoxifen is anti-estrogenic, but in endometrium it has some pro-estrogenic effect, because of which it leads to formation of endometrial polyps. Endometrial polyp can be either single or multiple, and mostly they are sessile, means without any stalk, but they can also be pedunculated, means with a stalk. Clinically, the patient may be asymptomatic, and but she can also present with abnormal bleeding, and clinical significance is that endometrial polyps can rarely proceed to adenocarcinoma in the endometrium. So lastly, the key points of today's lecture. So abnormal uterine bleeding can be caused by a variety of causes like endometrial polyps, chronic endometritis, endometrial carcinoma, but most common cause is DUB. And most common cause of DUB is anovulation. Endometriosis is defined as endometrial glands and stroma present outside the uterus at a ectopic location. and this ectopic endometriotic tissue may undergo cyclical bleeding, just like the normal endometrium. Adenomyosis is the presence of endometrial tissue within the myometrium. And lastly, endometrial polyps, they are benign exophytic growths arising from the endometrium. Thank you very much.